Anders Tegnell, who is Sweden's state epidemiologist and head of the Department of Monitoring and Surveillance at the Swedish Public Health Agency. I had the privilege of moderating a conversation with Dr. Tegnell back in April about Sweden's response to the COVID-19 pandemic. I am delighted that he's joining us again today as GMF's programming on the transatlantic approach to the coronavirus pandemic continues. I'd also like to give a special thank you to the Swedish Embassy for their excellent partnership in organizing this event. I want to invite all of you who are listening to join the conversation by sending in your questions using the Q&A button at the bottom of your Zoom screen. And you're also welcome to tweet out about the event. The hashtag is GMFTegnell, and you can also use our Twitter handle, which is GMFUS. Dr. Tegnell, when you and I spoke in the spring, as COVID-19 was spreading through Europe, states across the continent imposed dramatic lockdowns on their citizens. There was only one country that stood apart, and that was, of course, Sweden. Unlike France, Germany, the UK, Italy, Sweden did not close restaurants, bars, schools, or gyms. Schools for pupils age 16 and below remained open. Mask wearing was not mandated, and public gatherings of fewer than 50 people were permitted. Now, fast forward 6 months, Sweden is still grabbing headlines in terms of how it's approaching the pandemic. And over the past week, I've been reading lots of articles about what's been happening. And here's a sampling of the headlines that we're seeing now. Sweden's solitary voice in a crisis. Sweden swims against the tide. Making sense of Sweden. Sweden's virus plan was called lax. Can it be called a success? And here's where I want to bring you in. From where you sit, can Sweden's approach be called a success? And catch us up on the situation now 6 months from when we last spoke. So Dr. Tegnell, a warm welcome and over to you. And you're still muted.
Something about. So no, sorry about that. Thanks a lot for bringing me back here. I think we had a very interesting conversation last time, and I'm happy to be back. Let me start with just a few words on what's happening since last time. I mean, Sweden had a difficult spring. I think we should realize that. It worked out reasonably well, as our calculation shows that the pandemic peaked in Sweden the first part of April sometime. And then we had a slow decline of cases until we really hit very low levels from June and onwards. And during the summer, we had very low levels of spread in Sweden, probably one of the lowest in Europe. And during that time, the Swedish healthcare system continued to function very well. Of course, it meant that there was a lot of transition being made. A lot of anything that could be delayed was delayed. And there was a huge focus on treating COVID-19 patients. I think 70–80% of the patients in ICUs were COVID-19 patients for a while. On the other hand, there was always free beds in ICUs. Never less than 20% of the beds were free at any given time. Of course, there were regional variations, and a few patients needed to move from one region to the other. But on the whole, the health system coped extremely well. And now when you talk to them afterwards and they compare their figures with other countries, they also produced a lot of high quality healthcare, because the results from the Swedish ICUs and Swedish healthcare in general are at least as good as any other European country. So that worked out really well. We had a big problem with our nursing homes for a while, and that produced very high mortality, and that's the background to that we still have high levels of mortality. But since, I would say, middle of June, and even earlier, and so that was fairly quickly rectified, and cases in nursing homes fell dramatically. And our mortality rates have been on very low levels all through the summer, and is still on very low levels. So is this a success or not? I think we all need to be humbled when it comes to this pandemic, who has come back with such a vengeance in many European countries. So we should not feel safe. And we do see increasing numbers in Sweden too. Not dramatically so, and cases in hospitals and ICUs are still on very low levels. Our mortality rates are still on low levels, but it's definitely a concern. And we are instituting more recommendations on a regional level right now, and we are following the situation very closely to try to break this trend as quickly as possible.
I want to dig a little bit deeper on this. One of the elements of Sweden's approach that's gotten a lot of attention has been this issue of lockdowns. And for many who oppose lockdowns, who are advocates of small government, who feel that lockdowns are an infringement of individual freedom, they have held Sweden up as a poster child for a different policy. I've heard you say that, look, be careful here. I mean, maybe Sweden did not lock down the way other countries did, but you said Sweden had a virtual lockdown. Can you help us better understand what you mean by that?
Now, what happened is that we sort of asked people to minimize their social contacts. And people did that to a very high degree. We can measure it in some ways. We have asked people to what extent they have actually diminished their social contacts and follow our advice. And continuously 80 to 90% of the population says, yes, we have really changed our lifestyle a lot. And there's even been surveys in other European countries, and Sweden comes out as one of the countries where the population say they changed most, which I think is a sign that this advice we gave really sort of in practice gave a virtual lockdown. We can also see that on travel. I mean, domestic flights in Sweden stopped basically. They have started a bit again. Trains went down to, I think, about 30 or 40% of normal capacity. We can look at mobile phone traffic and see that people traveled or moved around 20% less than they normally do, which is a higher change than in our neighboring countries. And we still travel less compared to normal travel patterns than in any other country around us. So I think, yes, we had a virtual lockdown. We managed to achieve it mainly by getting the population to change their habits voluntarily, but also by having some strict measures in some aspects, like for restaurants, for example, we know that restaurants are places where there can be a lot of spread if you don't control them well. And so we gave a lot of regulations to restaurants. The local authorities are continuously inspecting restaurants to see that they follow those rules. When we now look into our contact tracing data, we can see that people very seldom are infected in restaurants. So that worked out. We also, as you said, cut down on big events. Another place where we know internationally it's quite often that you get big spread. And that has also been followed because legally we can only restrict certain events, quite few events, but in practice this level of 50 were instituted on all events voluntarily. So in practice, I would say that we had just as much of a lockdown as many other countries, but doing it with slightly different tools than many other countries did.
It's fascinating, your comment that 80% of Swedes have said they have changed their behavior as a result of these recommendations. And it underscores a point I've heard you make before about Sweden being a high trust society. And, in your role as an epidemiologist, what is your advice for countries like the United States that maybe don't have that high level of trust? As we see in the US, this has become a deeply partisan issue. So if the key is to stop transmission, and the way it's transmitted is people being together, and people aren't self-policing, how does a public health agency or a government try to stop that transmission?
It's very difficult because I think each country is different and the context is different. But I think what we have learned, not only from this time, but also from Ebola in West Africa and a number of other incidents, that you need to be able to have a dialogue with your population. You need to get your population to understand that we have a common goal in this, and get them to understand what really is important, not just telling people to put on masks or doing this or that, but really communicate that the main issue now is to try to meet as few people as possible close by, and then giving them the opportunity to sort of choose how they need to do it to be able to achieve that. I know this is difficult because it also builds on that there is a kind of trust between the agencies and the population, and that's something you don't change from one day to the next. That comes from a long time of sort of being together, and I mean, I think that's the lucky thing that we have in Sweden, that trust has been built up over years. And it's very stable. We usually quote our childhood vaccination program, a completely voluntary program, and we reach 98% of all children. 98% of all parents voluntarily go to their well baby clinic and get their children vaccinated. No coercion, no money exchanged. There is nothing happens if you don't go there. But people go there because they trust them and they trust the nurses there. And everybody sort of trusts that we all want what's best for their children.
So given that backdrop, I am struck that you have adjusted your approach with the second wave of COVID-19. And I'd like to draw you out on this. You know, seeing the recent rise in cases, I did note, and you referenced that you've issued some localized guidelines. There was one in the university town of Uppsala, and I know you were born there, so I thought I'd take that example, where you saw a spike in cases as students returned for the fall sessions. People have been told to avoid public transportation and in-person contact outside their households until November 3rd. I also noted that in mid-September, the Public Health Agency recommended for the first time that individuals who have a household member testing positive for COVID, that they should quarantine. Tell us a little more about some of these local measures that you're putting in place and how you're thinking about that.
Yep. First of all, we are in a different situation, and I mean, in the spring, we had a huge increase of cases with the importation from all over the world. And then we sort of needed to adjust our advice, our measures to that level of cases. Now, after the summer, we have a much lower level of cases. We have a healthcare with much more resources to be spared for more preventive work. And that's why we went for measures that we could not really do before because there was not just enough resources to do it. And one of them is to tell people in the same household to stay home if somebody in the household has tested positive, because that would make a bit more of a difference. And that would also make our contact tracing more effective now when we have resources to do contact tracing. So and we hope by that to sort of break the transmission a little bit more than with other measures in place. Then we have also, and that was true also in the spring, but not as much, that this pandemic is very much a regional. There's huge regional differences, both in number of cases, but also where the transmission takes place. And that's why we now have a dialogue with our regions when they get an increase, to try to understand, okay, what's your problem? Like, what's the problem in Uppsala? Oh, yeah, the problem started with a lot of students coming back. Uppsala is a huge student town. And we needed to, and there was a lot of transmission in those, not so much in the university as in all of these social events that comes with being a student town. So we all realized, okay, this is not a good spring for a lot of student events. We need to come together and tell the students, you need to cut down on this. And we managed to get the student unions to come along and the university to come along. And now we hope that this is going to have a big impact. We noticed the retail business told us that after 1 week in Uppsala, retail fell by 40%. So obviously people are listening and people are staying home, meeting other people a lot less already. And that will most definitely have an impact on the spread of the disease in Uppsala.
The other thing we're noticing about this second wave is it seems as though fewer people are dying than we saw in the spring. Is that just because it's early days still? Is it because the folks being infected are younger? What are your expectations of this next wave of COVID-19?
I think what we're seeing now in Sweden and many other European countries is that the new wave, a new peak of cases is very much about younger people. Probably because the mixing patterns are more intense among younger people, and the possibilities to spread there is much bigger. They also get much less symptoms. They very rarely get severely ill and so on. And I think especially after a severe lockdown, there is also a huge craving for more social contacts, maybe more in those groups than in other groups. So that's how it starts. In many European countries, it has then moved to a more generalized spread in all parts of the population. And unfortunately, we even see some increase in the mortality in some of the European countries. The development in Sweden is a little bit slower than in many other European countries. We hope we can keep it like that. We do see a spread also in other age groups in Sweden, but so far not in the age group above 70. So it's mainly in the sort of adult part of not the elderly part, maybe. And we do not see any increase in, we don't see any increase in mortality in Sweden. We have seen a little bit of an increase in the ICU intake. And that's why we're now working quite hard mainly with testing and contact tracing to try to contain this new development as quickly as possible.
So are the building blocks of a successful COVID-19 strategy essentially what they were in the spring, that it's testing, that it's tracing, and then isolating those who are sick?
Yeah, I mean, basically we're working with the same thing, with sort of the main goal really to try to cut down on social contacts as much as possible, and to convince people to stay at home when they are have any kind of symptoms. Now we can also say stay home when you have been tested positive, because now we have the testing capacity to test everybody with symptoms. But those are still the main blocks that we are working with, even if we are tweaking a little bit on them now and then.
And just right to this point, one of our listeners wanted to throw in a question saying that you recently recommended that the recommendations or regulations in Sweden for people aged 70 and over, you changed that. Why do this now when the numbers are increasing? Isn't this a big risk?
Yeah, I mean, it's something we discussed for some time, because the backdrop of this is really that the elderly people in Sweden has felt and have been very isolated. And that has really impacted on their mental health in many ways. And we have a number of discussions, a lot of dialogue with different groups among those. And we realized that since this is going to go on for some time more, we cannot really ask them to isolate them as much anymore. And then we were in a situation, yes, the spread is bigger than it used to be, but it's not near as much as it was this spring. And we have the hospital, the healthcare capacity to deal with cases now in a completely different manner. We also believe that this group is a very responsible group, and yes, they will change their behavior slightly, but not that much. So our expectations is really that this will not really change the epidemic very much. And we also need to understand that the driving part of this pandemic is not the elderly or the young people, it's the working age people. That's where the real drive of the pandemic is. So letting the elderly people have a little bit more of a social context, leading a little bit more of a normal life, which would improve their mental health immensely, is the way we consider it, a fairly low risk with huge benefits.
I'm sure it's a huge difference for elderly folks living in nursing homes to be able to have visitors at this point. You said, you're now able to treat this in a very different way. Maybe say a little bit more about that. And I know one of the factors driving the high death rate in Sweden in the spring were in fact those deaths in nursing homes. So just help us understand what's different now.
No, especially with the nursing homes, they've been through a huge transition, I would say. They were not very well prepared for this kind of onslaught that the pandemic was this spring. And many of them, far from all, but many of them had a lot of spread in their facilities. And of course, the people living there are the people that are most likely to die from this disease because they're both old and many of them have other chronic diseases. There was a huge effort being made, a lot of people being trained, a lot of equipment being put in place, procedures updated, testing being done in those places. And now the procedures are in place and we have actually seen very, very little transmission in those places during the last 2 or 3 months. And that's another reason why we do believe that opening up the society a bit for the elderly people would not really carry any risks. And yes, now you can go and visit your elderly relatives in those places, but you do have to follow the rules and regulations of the place. You need to be healthy, of course. You need to have a good hand hygiene. You will meet in special rooms, keeping distance. So there's a number of things in place to safeguard that we don't introduce the disease into these places again.
And I also have to ask you about face masks, because that is something that across much of Europe and in the US, citizens are encouraged to wear face masks. This has not been a policy that you've encouraged in Sweden. Why is that?
No, I think that the face mask issue is not completely easy. I mean, face masks in healthcare, in social care and so on, of course, has a long tradition. Everybody knows how to do it. They are very, very important, both to keep staff healthy, but also to avoid the spread from staff to the patients. So that's, of course, used in Sweden all over the place, no question about that. Face mask out in society is a different kind of thing. I mean, there's a long tradition about that in Asia. But in Sweden and Europe, it's never been like that. When you look at the evidence behind using face masks in society, they are not that great. Very few studies have been done. I saw one from CDC lately that showed that this face mask might not make that much of a difference. The other studies and also modeling and so on showing that, yes, they might make a big difference, but we don't really know. It's definitely our feeling or our belief that keeping distance is much more important. And fortunately, we are in a place in Sweden where we can keep distance. We are not a very crowded country. Most of our cities, with a slight exception of Stockholm, are not very crowded. We are also a rich country, which means that we don't have to fill our buses to 120%. So we can keep distance. And as long as that works, our strategy is not to use face masks. If that doesn't work anymore, of course, we'll look at face masks and maybe use them for a short period in some places. You also have to realize that the experiences in Europe are not that great. I mean, many of the countries are now looking at huge increase of cases, have had legal obligations to wear face masks for quite some time, and which does not say it could have been even worse without a face mask. Of course, we don't know that, but it's also quite clear that face mask is not going to be the silver bullet. It's not going to make that huge difference. And then I think it's a bit dangerous to believe that you can change so much by using face mask. But of course, there are places and times when they might make a difference, and then we will of course use them. So far, we've been able to cope quite well without them, and then I think it works better in Sweden without. I get mails from many Swedes coming back from other countries and saying, "Oh, happy they are back to be back and being without the face masks." Face mask is problematic, I would say. I'm worked in infectious diseases for a long time. It's something you use, but it's not something that you would like to use if you didn't have to.
Yeah, interesting. We have one of our listeners who wanted to jump in on the conversation that we were just having about nursing homes. And her question is, you mentioned that there were free intensive care beds at all times in the spring. And she's saying, but many old people in Sweden were not brought to the hospital. Why was that decision made?
I think that's an ongoing discussion in Sweden, and there are investigations going into that. So I'm not going to say that this did not happen, but you also need to realize that Swedish intensive care has a long tradition around looking very carefully about the patient that they admit into ICUs. I mean, going into ICU, you need to be reasonably healthy to be able to benefit from the treatment there. And I think that the clinicians in ICUs in Sweden are very good at choosing the patients that would benefit from their care and not accepting patients that this will only mean that they will get isolated and having a kind of treatment that will not help them, and the end will anyway be mortality just with a few more days in an ICU bed, which is not really neither nor ethical or morally way to take care of your patients. And when I talk to my ICU colleagues, they are quite convinced that they made the same choices during this time that they made at other times, and that the patients, the people that did not receive treatment, they were better off staying in their normal homes, and it would not have changed the outcome if they were admitted to hospitals. Of course, there might be exceptions. I'm well aware of that, and our inspectorate are looking into that to see if there was another kind of selection of patients at this time or not. We'll see what the outcome of that. But I think we need to realize that many of these people who are very old, very sick, would not have benefited from hospital care, or definitely not from ICU care, and that's a choice that needs to be made.
I now want to turn to the topic of immunity. And as you know, both supporters of Sweden's approach and detractors have often described Sweden's approach as one of herd immunity. You have said that is not what Sweden is doing. Help us understand the role that immunity does play in this. And, could we possibly be seeing lower numbers in Stockholm today because there is greater immunity? I know you were optimistic in the spring that the large numbers in Stockholm might have led to immunity in that population. Help us understand the debate around immunity.
I mean, immunity is important, of course. I mean, we know that from infectious disease epidemiology that the immunity of a population will very much affect the way that the disease is spread. We know that from the yearly flu. The normal yearly flu, where many people have immunity around it, really slows down the spread and diminishes the spread quite a lot. I mean, a normal flu season might result in some 4 or 5% of the population getting ill or something. When we have a flu that we are not immune to, we reach level 40, 50% maybe. So of course, immunity does have a role with any kind of infectious disease almost. There's a few exceptions, but not many. The immunity of COVID-19, how that works, we don't really know very well yet. But we do know that people do get immune because 6 months or more into the pandemic, we see very, very few cases of people who have been infected twice. So logic tells us, yes, people do get immune, and in some way, immunity will slow down the spread of the disease. At what levels that will happen and how it will happen, we are still learning, I think. Part of the problem is that the immunity in the population is not homogeneous. It differs enormously between different groups in the population. We know that certain parts of Stockholm, the immunity might be up to 25-30%. In other parts of Stockholm, it's only maybe 5%. And that, of course, means that there are still parts of Stockholm that are very likely to have quite a lot of spread, while other parts of Stockholm, maybe the immunity will break the spread, at least to a certain extent. So immunity is important. But of course, I mean, what's implied in saying that Sweden goes for herd immunity is that we're sort of sacrificing people to reach that. And that is something I would like to deny very much. Once again, we have never even thought about sacrificing anybody around this. We are really trying to get the spread of the disease to be as slow as possible, using means that are not hurting the population more than it's helping them. But in the long term, of course, even COVID-19 and immunity to COVID-19 will definitely affect the spread of the disease very much. And if we get a good vaccine, that will help us reach those levels quicker than the disease in itself will do. It will not eradicate the disease. I would be very, very surprised if we ever eradicate this disease, but it will help us to handle it in a much more effective way than we do today.
So several of the folks who've tuned in for this session are deeply interested in this debate around immunity. And a couple of the folks are citing a study from Imperial College in London. And according to these listeners, researchers there concluded that the proportion of people in Britain with antibodies that protect against COVID-19 declined over the summer. And so the question is, the study results indicated that immunity to COVID-19 may be short-lived and suggests skepticism about this idea that we'll see greater immunity developing in the population. Can you speak to that?
Yeah, I mean, we need to realize that when we measure the level of antibodies, then we're only looking into one small part of the immune system. And we don't know what is a protective level of antibodies for COVID-19 yet, because there is no data on that. So yes, there are several studies, not only Imperial College, that shows that at least for some people, the antibody levels falls rather quickly, which is of course interesting, but the real thing is, of course, how many people do get sick a second time. I mean, that shows the real immunity, not just the level of antibodies. And I think that's the most important thing to follow, and that's followed very, very carefully all over the world. And I think last count I saw a week ago or something like that so far we have found 20 people in the world who has had the disease twice. And of course, considering that hundreds of millions of people have had the disease, the risk so far is not very great. On the other hand, in the long term, yeah, most likely this is not a disease that gives you lifelong immunity. I don't think that, and other coronaviruses don't do that. But it will definitely be with us for 6 months, for sure, we can tell already. And it will probably also stay for the majority of the population for quite a lot longer than that. And it will definitely make an impact on the spread of the disease, I believe. And it will not fall as quickly as the data from Imperial College shows, because then we would have a lot of more cases of people coming back with a second infection.
Mm-hmm. Interesting. So another topic that a lot of our listeners are interested in is schools. And they're very interested in the Swedish experience with keeping schools open. How do you manage it? Is it the health authority that is making those decisions together with a school board? Are you seeing teachers and staff getting sick? Just what's the experience been over these past 6 months?
We had a lot of discussion with the school authorities on the national level in the beginning of this, and based on the data from China showing that children very, very rarely got severely ill, and also that a lot of the early report from China also said that children very rarely are infecting other people, even if that's often difficult to measure in any reasonable way. And that coupled to that, we know that having children in school are very important for their health, short term and long term. And we can also now see from other countries so close to schools that children are really suffering. I mean, that's a big concern, I think, that children are really suffering all over the world from not being able to go to school. abuse in home increases, malnutrition increases. So many things happen when children are not able to go to school. So you really need to think carefully about closing schools, especially if you do it for any longer time periods. And that's why we decided to keep them open and follow it carefully. And I would say that during the spring, we saw almost no outbreaks in schools. We saw a few outbreaks, but then among teachers, obviously teachers infecting each other because there were no children involved. And it was very clear that it was a teacher coming back and infecting colleagues in most cases. We have afterwards looked at the rate of teachers being hospitalized with COVID-19, and it does not differ from other professions. It looks like it's lower than quite a lot of professions. There are other professions that have a higher risk of ending up in hospitals. Of course, this is a complicated matter also connected to socioeconomic issues and so on, but we do not see that teachers are more affected than anybody else. If anything, they are affected less than anybody, most other people. What we see now after the spring, because in the spring the high schools were closed, as you said, we do see that high school students are different. I mean, in those 15 plus children, there is some spread. They don't get severely ill. Teachers don't seem to be very much affected, even if they are affected a little bit more than teachers of younger children. But there we do see some spread. So of course it's not an on and off button, but the younger the children are, the less sick they get and the less they spread the disease. And I would say that our general experience with keeping the schools open are very, very positive. And we do also get a lot of feedback from parents from many places in society that they are very happy about that we kept the schools open. And I would say that most countries in Europe now are going that way. The risk of keeping schools open are not very great, and the benefits are very, very big.
And just so I'm clear, did the high schools and universities open in the fall?
Yep, they open in the fall. High schools completely. They are now back to normal teaching. Universities do a bit of mixed teaching, which some of them did already before. Some of it on distance, some of them physically in place.
Mm-hmm. Interesting. I mean, that's going to be a fascinating model for the rest of us. I mean, I live in Washington, D.C., and nothing's open. I mean, none of the primary schools, which also has a knock-on effect. I mean, it has a very clear effect on the children, but also the parents who then need
exactly,
to
especially if you ask parents to work from home. Working from home is okay, but working from home, if you also have to take care of your children who are at home, that's not a very easy combination to deal with.
So I now want to open another topic on which we've got a lot of comments, and it has to do with the development of the vaccine. And I want to read, it's a slightly longer comment, but it's quite poignant, from one of our listeners who's living in Belgium. And she writes, the understanding here and in many European countries seems to be that the only thing that works is a lockdown. And the Belgian government will likely announce a second lockdown this coming Friday. The damage from the second lockdown is likely to be even bigger than from the first one. And yet, this is the only approach that can work, so we are told. They tell us that we have to wait for a vaccine, reportedly to be available in March 2021, and this will bring the end of the pandemic. At the same time, some experts argue that a vaccine may not end the pandemic due to possible issues related to the vaccine itself, availability, etc. What is your take on this argument that if we want to resume normal lives, we will have to wait for this vaccine and for all to be vaccinated?
I think we need to realize that we are now waiting for vaccines that we don't know very much about so far. I mean, the trials, what we know from the trials, they've been reasonably successful, but we are also looking at vaccines that are of a different kind than any of the vaccines that we're using today. I'm not saying that that's a bad idea. It's the kind of vaccines that have been worked on for a long time, but they have never been mass produced. They've never been used on a massive scale before. So that's a little bit of a concern. I think that the safety issues can be handled, but we need to realize that the efficacy and the long-term efficacy of those kind of vaccines, we don't know too much about. We don't know how well they will work on the elderly and so on. But I think the main issue is that yes, deliveries will start somewhere reasonably early next year, but they will be spread over a year or two, which means that we will not have a vaccine that will affect the spread in the population for at least, earliest next fall, if we are lucky. Because we do really need to vaccinate probably around 40-50% of the population to see any kind of reasonable effect on the spread of the disease. So yes, a vaccine will definitely help us, but it will not let us come back to normal life for quite some time yet. It will hopefully help us to protect the elderly and the risk groups. I think that's the most important thing we can think about to start with. That will make a difference and help us also protect healthcare workers and so on. That will be important. But for society at the large, it will take much longer before it will have an effect. And we also need to realize that we need to convince the population that they need to get vaccinated. If we go back to the swine flu pandemic 10 years ago or so, that was not an easy thing to do. I know that in France, they managed to reach, I think, 3 or 4% of the population. In spite of that, there was plenty of vaccine available, and they did a lot of effort to try to convince people. And of course, if we end up in the same situation this time, that large parts of the population are not interested in being vaccinated, which is maybe, there are some polls saying that 50-60% of the population might get vaccinated in Europe. It might be more, but for great parts of the population, they might look at it that they are not going to get severely ill. And I think that's part of the reason why we see so much of a spread in the younger parts of the population in Europe right now. Many of them, their risk calculation is that the risk for me to get corona is not that great. And to convince them to get vaccinated for the good of society, that will maybe not be that easy. So I'm highly skeptical about saying that, yes, once we get the vaccine, we can forget about lockdowns and everything else and just go on living like we always did. It's going to take quite some time before we reach that level.
That's sobering, but important for all of us to think through the implications of that. We have another listener who is very interested in your opinion on why China is doing so well fighting this virus. And of course, China is also vaccinating people as we talk right now. So what about the Chinese example, and can we learn from that?
Yeah, I think that's difficult. We don't know too much about China. We know some things. They've used extremely drastic measures, and I'm not too sure about the acceptability of those level of measures in Europe, at least, and probably in many other countries too. It's obvious that those kind of drastic isolation measures do have an impact, and quite a big impact. And if you can get an acceptance in the population for doing those, obviously, like in China, you will have a very good effect. If that will work in the long term, it still remains to be seen. There has been some new outbreaks in China. They've managed to contain them very quickly, of course, by using the same drastic measures again. Now, when we're going back in Europe to the same drastic measures that we used this spring, there's quite a lot of opposition to it. So I think we need to realize that these are different cultures, different political systems, and there are limited things we can learn from China, unfortunately, because I think that many of the things used there would not be acceptable in Sweden and probably not in most European countries.
You mean in terms of the surveillance they're doing of?
In terms of the surveillance they're doing, in the terms of sort of drastic measures against individuals if they don't follow exactly the rules, in terms of the self-isolation that are imposed on huge groups of the population for extensive times.
And would you, if you had the opportunity to be vaccinated with the Chinese vaccine, would you take that?
Since we don't know that much about how it's actually been tested and so on, I would prefer to use a vaccine that's gone through by our European Medical Agency, where there's a lot of transparency about the tests and so on that's been done on it, so that we can feel very safe about that we're using as safe as vaccine that's possible to make.
Yeah. Well, and to your point that there's a lot of skepticism in some of our countries about vaccines in general. It's probably quite important that whatever go to market not have immediate negative side effects for lots of people. One thing that's really striking about your approach to COVID-19 is the holistic view you have of public health. And it came through very clearly when you talked about the regulations being lifted on visiting nursing homes, because you want to think about the psychological well-being of the elderly in Sweden. It comes through when you talk about schools and the impact that not going to school has on children. And we have a couple questions that are asking about the impact of some of the COVID-19 policies on business in the retail sector. And you talked a bit earlier about the impact on the retail sector of some of the new regulations. And there's interest in hearing from you what kind of dialogue or coordination there is between the health authority and business and industry as you think about what approach to put into place.
I think in different ways. When it comes to sort of the economic consequences and so on, I mean, then that kind of dialogue is done by the government. It's not the public health agencies. We are not involved in any kind of subsidies or anything like that to companies that are not running that well. On the other hand, we have a lot of dialogue with different actors on how they can participate in making it easier for people to not being crowded. Just this morning, we had a conversation with the union of the retailers in Sweden, who really wants to get our advice on how do they arrange the stores and the selling and the big shopping malls and so on. How do they arrange things to minimize the risk of spreading those? So this is really, I think, an area of collaboration. Of course, they are very open with they need to keep on selling things, but on the other hand, they're also quite open to getting any kind of advice on keep on doing that with as little risk as possible. And I think they're also quite prepared to take some losses rather than having the risk of being sort of closed down completely. So I think this has been quite a good dialogue, and I would say that many of the stores in Sweden have done a very good job on that. There are a lot of markings in the floors on how to keep a distance. Many stores have a system for not letting too many people in at the same time. Many stores have employed special people that go around telling people to keep distance and stuff like that. So I think they've really done their share in the sort of community thing around making it possible to keep a distance in different places in Sweden.
So I'm personally very interested in what you have learned over the past 6 months about this disease. And when this began, we were very focused on the damage that COVID-19 does to our lungs. It now seems that COVID-19 affects a lot of other of our major organs, including our heart. And what have we learned about this disease and how it attacks us over these past 6 months?
Yeah, clinically, I think quite a lot. And as you say, it's probably one of the infectious diseases that affects most different parts of our body in many different ways and in surprising ways. I mean, taste, for example, one of the fairly common and maybe one of the most common symptoms of COVID-19. Some people even say that this should maybe be the best way of measuring how many people actually have been having had COVID-19, and it's asking if they lost taste at any given time, because that's very common and can keep on for extensive period of time. So it's really giving a lot of odd symptoms, even for an infectious disease clinician, I would say. And also the way it spreads, because it spreads in such unusual patterns. It does not spread, if we say that individuals seems to spread the disease so differently. There are studies saying that maybe 80% of everybody getting it are not spreading the disease to anybody. while the last 20% are spreading it to a lot of people. And that makes for a kind of spread that's unlike most other diseases that we know about. And that's, I think, what's behind this kind of clusters of super spreading events of that we see a fair amount of. And that's also has made that we need to do our supervision, and it needs to do our measures, tailor them slightly differently than we do for many other diseases, because these big outbreaks and so on are much more driving in this disease than in any other disease. So it's a very different disease than from, I would say, any other infectious disease we have had to deal with in the last decades or so.
Mhm. Well, your comment just now engendered a couple of questions, so let me just ask you those right now. One is that isn't losing taste connected to not having enough zinc in your body? And the other is, what do you think about the use of sniffer dogs to detect people with active infections? This has been used in Finland and elsewhere. Is this a viable alternative to PCR testing? Back to you.
No, I think the taste is more about that this virus seems to be affecting our nerve system in different ways, because there's also quite a lot of people describing other losing sensibility on your skin. There's a number of ways that this virus seems to affect our nerve system. So I think it's more connected to that than anything else. The sniffer dogs are very interesting. And I'm sure there are places and times when they're going to be useful. But it's a question of how many sniffer dogs can you actually produce in a short term. I think there is a good complement, but they will not really replace normal testing and so on. But it's going to be quite interesting to see how the Finns are using them in airports and so on, and how much of an impact that has.
Interesting. And I want to ask you also about, are we getting better at treating COVID-19? I think the human condition is such that we always want there to be a silver bullet, and you've made very clear there are no silver bullets when it comes to COVID-19, and a vaccine won't be a silver bullet, which then leads to the question of, okay, if we can get better at treating this, then that's another avenue, a path forward to normality. And it does seem that we've learned some things about when to use blood thinner and when to use ventilators, but talk about the treatment side.
Yeah, it's not something we follow that closely to public health agency, but I would say in general, that's been, while the vaccines seems to be quite successful. We have a lot of vaccines coming up. A few of them, 5 to 10, are very close to starting to be used. So that's really been a success story in many ways, even if it's not going to be the complete silver bullet. While the treatment has proven much more difficult to get something that actually sort of stops the viral disease that affects the viruses. None of the treatments tried have been really all that good. On the other hand, technically, I would say ICU doctors and clinicians have become much better at handling the patients, which means that they are much better at choosing which ones to put on ventilators, how to ventilate them the best way, and so on. So I think that the survival rate in hospitals has probably increased quite a lot. And also the needed treatment periods and so on has been shorter. And of course that's good, but it does not really, it's not a big change, and it will not really, I think, affect our way of looking at this as a severe disease that we really need to be careful about.
So we're getting near the end of our time, and I want to ask you, when you think about all the things you've learned over these past several months around COVID, and you think about the Swedish experience, which necessarily is unique because each of our countries has different societal norms and different senses of individual responsibility, and what you've talked about and trust in government. What are the lessons you have learned that you would say are transferable to other countries, that you want to make sure we who are not Swedish keep in our heads as we, sounds like, have another at least year to try to manage this?
I think many of them we have learned in many countries. I mean, one of them is how careful we need to be about nursing home and the elderly part of our population, because how vulnerable they are and how this disease will affect them so severely. And that we need to be really careful in the institutions that treat our elderly people. I think that's something we have learned and paid dearly for. So I think that's very important. The other part is also to have supplies in place for our hospitals and for our hospital staff, because that's been a fight all over the world to be able to keep everything needed in place all the time. And I think this just-in-time delivery methods that are very apparent in Sweden and in many parts of the world these days, we need to adjust them, I think, to a certain extent to be able to supply our health staff with reasonable ways of working. And also maybe in the end that our society needs to understand that crowding is something that can be dangerous, and we maybe need to think about how we're building our cities, our societies in a way that we don't assume that crowding is going to be okay. That we build it in a way that's easier to move back and forth between working and home without having to use public transport all the time and things like that. So maybe those kind of things will also be apparent to us, that crowding is in itself a dangerous thing, and that as humans there is a need to have a little bit of space around us to be a bit safer.
Well, Dr. Tegnell, I think you and your colleagues across Europe and here in the United States have made clear to all of us the importance of public health officials and the importance of facts guiding the policies we put in place. And one thing that really sticks with me from the comments you've made is the importance of whatever approach we put in place being sustainable over time, and that we need both government action, we need public health officials giving us their best guidance, but there's also a critical role for individual responsibility and all of us then following through on that guidance. And I just thank you for being such a clear messenger on that point as well. And it sounds like that's going to be a key part of us getting through the next year with as few people as possible getting sick, but an even smaller number dying. If there's any message along those lines you want to close us out with, please let me hand it back to you.
No, but I think you're very right. I mean, we need to find a way to live with this disease that are not hurting our societies more than absolutely necessary. I think that's very clear. And those ways will be different in different countries. I think that's also quite clear. But we need to think about this in the long term. And to do that, we all need to take responsibility. This cannot be handled by any one individual or any one institution or any one politician. And it's not either a way we can buy our way out of. We really need to work together to make life bearable for the next 12 months.
Well, Dr. Tegnell, I want to let you know that everything in the Q&A box right now is saying, thank you very much, Dr. Tegnell, for a fascinating conversation. For those of you who have tuned in, wonderful to have you. Terrific questions. This session has been recorded. It'll be posted to GMF's YouTube channel. You're welcome to watch it. Encourage others to watch it. I think the more knowledgeable we are about this disease, the better poised we'll be to manage it. And Dr. Tegnell, I will look forward to inviting you back in 6 months and doing another stock taking. But in the meantime, I wish you well, and thank you so much for making us smarter about COVID-19. Bye-bye.
Thank you so much for having me. Bye-bye.
Bye-bye.